Respected Chairperson, sir, respected delegates, good afternoon all of you. My topic is neutropenia, the clinical approach. So what is neutropenia? In WBC series, in the major lineage is the neutrophil, and the neutrophil is having a host defense mechanism. If there is a decrease in the neutrophil count, we are calling it the neutropenia. So if the normal in adult individual, the neutrophil count is approximately 1500 to 8000 per microliter. But if the neutrophil count is less than 1500, it is usually termed as neutropenia. It is again graded into three grades: mild, moderate and severe. If the neutrophil count is less than 1500 but more than 1000, it is mild. Less than 1000 but more than 500, it is moderate. But if the neutrophil count is less than 500, it is called severe neutropenia. Sometimes in peripheral smear, we are getting the pseudoneutropenia. If there is a delayed examination of drawn specimens, if there is a paraproteinemia, or if there is a anticoagulants. Neutropenia. Neutropenia broadly divided into 2-3 classifications. It could be acquired neutropenia, or it could be congenital neutropenia. It could be acute neutropenia, or it could be chronic neutropenia. So please come one by one. In congenital neutropenia, we are having Costman syndrome, cyclic neutropenia, neutropenia with phenotype anomaly, etc., etc. But in acquired neutropenia, the most common is the infection, then second is the drug and chemical induced, nutritional immune neutropenia, Feltis syndrome, complement activation. What are the common infections? As I told, it could be viral, it could be bacterial, it could be fungal, it could be protozoal, or it could be rickettsial. In viral infections, so hepatitis B virus, Epstein B virus, HIV. In bacterial, mostly the gram-negative infections, sometimes brucellosis, typhoid. Fungal infection, the histoplasmosis. In protozoal infection, it is malaria, and in rickettsia, it could be the typhus fever. The viral infection, many viruses cause neutropenia, but mostly they are the transient neutropenia. Rarely have any clinical significance except few. Few viruses can cause prolonged neutropenia, specifically hepatitis B virus, Epstein B virus, and HIV virus. How? The mechanism is by direct marrow infection or by production of the autoantibody, and they can cause dangerous clinical illness. Bacterial induced, the most common by the gram-negative endotoxin. Special population, specifically the neonates, undernourished, alcoholic, and post-chemo radiotherapy patients are more susceptible for the neutropenia. Most cases experience short episode. Rare case with progressive neutropenia and overwhelming neutropenia may benefit from the granulocyte colony stimulating factor. And another important aspect is neutropenia in our clinical practice we are getting, that is a drug induced. That first described in 1931 with aminopyrin. The incidence of drug induced neutropenia is approximately 1 to 3 million per year. Usually they are underreported. Mechanism of drug induced neutropenia, most probably the immune mediated, dose-dependent inhibition of granulopoiesis, direct toxic to myeloid precursor or marrow micro-involvement. The immune mechanism, specifically the heptin-induced antibody, aminopyrin, penicillin, antithyroid drug and gold can cause neutropenia, or there may be circulating immune complex or quinidine-induced neutropenia. Dose-dependent suppression in clinical care or critical care, we are getting beta-lactam antibiotics or carbamazepine or valproic acid. Direct marrow damage by few drugs, if there is patient is having genetic predisposing, slow acetylator and sulfasalazine is responsible for that. Captopril-induced agranulocytosis in renal insufficiency, cumulative dose of phenothiazine onset after 3 to 4 weeks, we are getting the neutropenia. Treatment. If we are having the drug-induced neutropenia, the first and foremost treatment is withdraw the drug if possible as early as possible. Granulocyte colony stimulating factor indicate only in refractory cases. Autoimmune neutropenia. It may be transient or it may be prolonged, associated with several conditions, mostly the Wegener's granulomatosis, rheumatoid arthritis, SLE, other collagen vascular disorders, chronic hepatitis, systemic infection, or maybe in malignancy. In adult, usually take prolonged but benign clinical course. Skin and lower respiratory tracts are most common site of autoimmune neutropenia. The secondary autoimmune usually have poor prognosis and depends on the associated autoimmune disease. Primary isolated immune neutropenia rarely need treatment other than the supportive care. There is uncertain benefit of granulocyte colony stimulating factor. Risk assessment. Now come to the clinics. If you are getting a neutropenic patient in your chamber or in your hospital or in the clinical rounds, first you assess the patient, whether the patient is a high-risk patient or it is a low-risk patient. Depends upon your risk assessment, the treatment should be accordingly. If the patient is low-risk patient can be treated with oral antibiotics, isolation, or in the home-based treatment or OPD-based treatment. But if the patient is high-risk patient, the patient should be immediately treated in the hospital with broad-spectrum empirical antibiotics. And you have to choose the duration of antibiotic depends upon the risk assessment, whether it is a low-risk patient or it is a high-risk patient. Who are the high-risk patients? If the patient is having a profound neutropenia, neutrophil count is less than 100 cells per microliter, or if there is patient is having fever for more than 7 days of duration, patient is elderly patients more than 65 years old, or several clinical comorbidity, medical comorbid conditions including hypertension, pneumonia, hypoxemia, COPD, if the patient is having acute leukemia, or depends upon the intensity of the chemotherapy. If the patient is having intravascular catheter, if the patient is having central line, they are the high risk patient. And if the patient is having MASCC score less than 21, they should be treated immediately in the hospital with empirically high dose antibiotics. Who are the low risk patients? If the patient is less than 65 years, there is no medical comorbidity, MASCC score is more than 21, and brief period of fever less than 7 days of duration, they can be treated in the home or by OPD basis or with oral antibiotics. What is MASCC score? The Multinational Association for Supportive Care in Cancer Risk Index score, that is a MASCC score. If it is less than 21, patient should be treated as a high risk patient. If it is more than 21, patient can be treated as a low risk patient. Now, you have been determined it is a high risk patient or low risk patient. Patient can be treated in the OPD or IPD. Now what you have to do? If the patient is in the IPD or in the OPD, whatever, next the blood or lab report is the most important to assess the next course of treatment. Complete blood count, serum electrolytes, renal function test, liver function test should be sent to all patients in routinely. And the most important, in neutropenic patient, we should send blood culture. 2 sets of blood culture should be sent from the 2 different venipuncture site, and we should do for a routine chest X-ray to see any respiratory signs or symptoms. Other sepsis markers we may send in the form of C-reactive protein, the procalcitonin, or other. If you need or if you feel so, you can send it. When should we obtain the blood culture again? If the fever persists for more than 72 hours in spite of empirical antibiotic therapy, the second sets of blood culture should be sent. Or if there is a sudden clinical change in the patient's clinical condition or deterioration, we should send again repeat blood culture. Now come to the empiric antibiotic therapy. What type of antibiotic therapy you should start? In high risk patient, start with the monotherapy with an anti-pseudomonal beta-lactam agent such as cefepime or carbapenem, specifically imipenem, cilastatin combination or meropenem combination, or you can start with the piperacillin tazobactam combination. If you find the patient is having penicillin allergic patient with a history of an immediate type hypersensitivity reaction, it should be treated with ciprofloxacin plus clindamycin or aztreonam plus vancomycin. Other antimicrobials, specifically aminoglycoside, fluoroquinolones and vancomycin may be added to the initial regime for the management of complication. In high-risk patient, modification of initial empiric therapy may be considered for patient and risk for infection with the following antibiotic-resistant organisms, particularly if the patient's condition is unstable, patient condition is deteriorated, or if the patient is having positive blood culture reports suggestive of resistant MRSA, VREA or ESBL producing gram-negative organisms. Risk factors include previous infection or colonization with the organism and treatment in a hospital with high rates of endemicity. For example, bacteremia due to viridans streptococci may result in shock and ARDS. Gastrointestinal mucositis, septazidim use, and prophylaxis with ciprofloxacin or levofloxacin are important risk factors for developing serious viridans streptococcus bacteremia during neutropenia. This type of patient should be isolated and should give the Berian nursing if it is in the ward or if the patient is in ICCU. In our ICCU, in such type of patients, ideally we have separate cabin for that patient type of patients in our ICCU, and we have done the Berian nursing in such type of patients. High risk patients, if the patient is having MRSA, VREA, ESBLs, if MRSA, consider early addition of vancomycin, linezolid or daptomycin. In VREA, consider early addition of linezolid or daptomycin. ESBLs, consider early use of carbapenem, mostly either meropenem or imipenem. Sometimes we are using now the higher dose of doripenem also. High risk patients, afebrile neutropenic patients who have new signs or symptoms suggestive of infection should be evaluated and treated as high risk patient in all aspects. Empiric antibiotic therapy for the low risk patient. Low risk patient, we can use ciprofloxacin or amoxicillin clavulanic acid in a combination for oral empirical treatment. Other oral regimens include levofloxacin or ciprofloxacin monotherapy or ciprofloxacin plus clindamycin are less well studied but are commonly used. So in general consideration, once blood culture results and organism susceptibilities are available, they may direct a more specific choice of antibiotics. A single blood culture positive for coagulase negative staph should generally be dismissed as attributable to a contaminant, assuming that a second set of blood specimen have been drawn that have a negative culture results. So, the initial management of fever and neutropenia, if the fever is more than 38.3 degrees centigrade or neutropenia less than 500 cells per microliter, risk assessment is most important, whether it is a low risk or it is a high risk. If it is a low risk patient, OPD based treatment with oral antibiotics, high risk patient, IPD based treatment with empirical high dose antibiotics. Indication for addition of antibiotics active against gram-positive organisms to the empirical regimen for fever and neutropenia. When you should use the gram-positive antibiotics? If the pneumonia is documented radiographically, if there is a positive blood culture for gram-positive bacteria before final identification and susceptibility testing is available, if there is a skin or soft tissue infection at any site, severe mucositis, if fluoroquinolones prophylaxis has been given and ceftazidime is employed as an empirical therapy. When and how should antimicrobials be modified during the course of fever and neutropenia? This is very important. When we should escalate the treatment or modify the treatment in our clinical practice. 4 points you have to be careful. Modification to the initial antibiotic regimen should be guided by clinical and microbiological data. If vancomycin or other coverage for gram-positive organism was started initially, it may be stopped after 2 days if there is no evidence for a gram-positive infection. Patient with unexplained fever who are responding to the initial empirical therapy may be maintained on that initial regimen until the recovery of absolute neutrophil count to more than 500. If they have initiated IV antibiotics, patients who meet criteria for being at low risk and can tolerate oral medications may be candidates for transition to combination of oral antibiotics. Unexplained persistent fever in a patient whose condition is otherwise stable rarely requires an empirical change to the initial antibiotic regime. If an infection is identified, antibiotics should be adjusted accordingly. It is very important. When and how should antimicrobials be modified during the course of fever and neutropenia? As already I have been told, there is no proven advantage to adding vancomycin empirically in the setting of persistent or recurrent fever and neutropenia. For patient with recurrent or persistent fever, consideration should also be given to the non-infectious causes such as drug-related fever, thrombophlebitis, and underlying the cancer itself, and resorption of blood from a large hematoma. Most in clinical practice, we forget about the thrombophlebitis, drug-related fever, and other things. And if the patient is having some documented infection, we have to modify our antibiotics accordingly. Now the next question is, if we have been started the antibiotics, how long we should give the antibiotics? It's very common and clear-cut guidelines is there. In patients with clinically or microbiologically documented infections, the duration of therapy is dictated by the particular organism and the site of infection. Appropriate antibiotics should be continued for at least the duration of neutropenia until the blood count above 500 or longer if clinically necessary. If the patient is having unexplained fever, it is recommended that the initial regimen should be continued until there is a clear signs of marrow recovery. Alternatively, if an appropriate treatment course has been completed and all signs and symptoms of a documented infection has been resolved, patient who remain neutropenic may resume oral fluoroquinolones prophylaxis until the marrow recovery. So this is the how long you should continue the antibiotics in a neutropenic patient.
Dr. Sharma, try to wind up.
Yes, sir, 2-3 slides. Now, should we give the antibiotic prophylaxis? High-risk patient, sometimes we may give the antibiotic prophylaxis. Antibacterial prophylaxis is not routinely recommended for low-risk patients who are anticipated to remain neutropenic for less than 7 days. Antifungal therapy, not routinely used unless or until you are suspecting any fungal infection or added infection or again clinical deterioration of patient's condition. So in routinely, we should not give the antifungal prophylaxis. Antiviral prophylaxis, that is also routinely not used. Routine treatment for respiratory syncytial viral infection in neutropenic patient with upper respiratory disease should not be given, Role of granulocyte colony stimulating factor. CGSF are not generally recommended for treatment of established fever and neutropenic. Sometimes in prophylactic cases, we may use it if the neutropenia is suspected more than 20%. Catheter-related infection, we should take care of. And the last slide, environmental precaution. Each and every hospital personnel, healthcare personnel, doctors, sisters, and everybody, hand hygiene is the most effective means of preventing transmission of infection in the hospital in a neutropenic patient. Standard barrier precaution should be followed all patients, and infection-specific isolation should be used for patients with certain signs and symptoms. Plants and dried or fresh flowers should not be allowed in the rooms of hospitalized neutropenic patient. Hospital work exclusion policy should be designated to encourage healthcare personnel to report their illness or exposures. Vaccination for the visitors as well as healthcare personnel, including annual influenza, measles, mumps, rubella, and varicella infection should be recommended for all healthcare personnel in private as well as in government setup. Thank you, sir.